Mode.
Such power. Wow, that's great. Well, good morning and welcome to the last Friday of winter. So we've been struggling since the early 1980s about how to prevent transmission of HIV, and we continue to look for a vaccine, etc. But one of the newest and most exciting avenues has been pre-exposure prophylaxis, and we're going to hear something about that this morning from two speakers locally who are very much involved in the project. Amy Matheny serves as Clinical Assistant Professor of Medicine at the Family Medicine Residency of Western Montana, which is sponsored by the University of Montana and affiliated with the University of Washington Family Medicine Residency Network. She practices family medicine at Partnership Health Center, including HIV primary care and hepatitis C care, and precepts residents and medical students. She received her BA in Biology and Chemistry from Providence College, her MPH from the Harvard School of Public Health, and her MD from the Albert Medical School of Brown University. Dr. Matheny completed her family medicine residency training at the Family Medicine Residency of Idaho in 2012. Kerry Haney is an assistant professor at the University of Montana Skaggs School of Pharmacy and Family Medicine Residency in Western Montana. Her clinical practice site is located at Partnership Health Center, where she coordinates pharmacy student rotations and assists with precepting family medicine residents. Since 2011, she's worked with the Partnership Ryan White Care Team to assist with medication-related care issues. She received a BS in pharmacy from the University of Wyoming and a PharmD degree from the University of Montana. Dr. Haney completed a general pharmacy practice residency at Overlake Hospital Medical Center in 1998. Welcome to both of you.
Can everybody hear me okay? All right, well, it's a pleasure to be with you today, and we're really excited to be able to present to our clinical community about PrEP. This project actually is part of a few different presentations happening in our area. The Regional Resource Network program is part of the national effort for HIV prevention, and a representative visited our area in the fall of 2015 and really noted with a needs assessment that more education on PrEP, both for patients in the community and for providers, was needed. And so this talk, along with a few other community talks happening around this time, were envisioned to try to improve people's understanding of PrEP and hopefully uptake of PrEP. And so we'll highlight another upcoming talk that's really focused on patients in the community at the end of this lecture, but our goal is to really focus on clinicians. And there's a number of different local advocacy groups, clinics, and others that are involved in HIV care and advocacy that help put these talks together. Dr. Haney and I have no conflicts of interest to disclose, and our goals for today are to start with some perspective of HIV in Montana. As you're probably aware, we're a relatively low prevalence state, but it's still important to have a sense of the demographics of who our patients are that have HIV and who's subsequently at risk of getting HIV, and ultimately how to prevent that from happening. We'll summarize some of the data for the effectiveness of PrEP, and I'll talk a little bit about the drug itself, talk about candidate selection, and ultimately the nitty-gritty of how to prescribe PrEP and follow-up monitoring of that. But really our overarching goal is to empower, especially primary care providers, but really all of us to have a sense of what PrEP is and how to manage PrEP so that it's not just relegated to HIV clinics, because those patients probably aren't coming to our clinics anyway, since hopefully they don't have HIV yet, or reproductive health clinics where patients are getting STI screening. Really, this is part of essential primary preventive care. So to talk about some national trends, and this is CDC data from the end of 2012, most recently available data. The prevalence of HIV in the United States is about 1.2 million persons who are infected for age 13 and older. And this is somewhat of an estimate because it's estimated that 13% or 1 in 6 patients with HIV don't know they have HIV. So obviously that's an incredibly important issue in another respect of making sure people are getting screened, not only for treatment as soon as possible, but also obviously the risk of spread of infection from folks who don't know they have it. The incidence of HIV is about 50,000 new infections per year, and we'll see later that that number has not shifted very much for many years, and why PrEP is so important to know about. About 2/3 of new infections are in men who have sex with men, or MSM, and there's significant racial and ethnic disparities in HIV incidence. For example, for Black and African American men and women, the rate is 8 times that of whites, and so that's an important thing to be aware of as well. It's estimated, though, that 500,000 to 1 million patients in the United States are at considered substantial risk for HIV acquisition, and we'll talk later about what does that mean and who are those risk groups? But obviously a significant number of patients that may benefit from PrEP, and those are patients in all of our clinics, whether it be primary care or other settings. And Montana, being a relatively low prevalence state, is ranked 47th in 2013 for new HIV infections. I thought this was a great slide from our local Department of Health and Human Services for Montana that really highlights our prevalence over the last few years as well as our incidence. We have, between 2010 and 2014, about 566 people in Montana living with HIV, and in that time there were 100 new infections. You see there's a split of about 84 men and 16 women. There's overrepresentation of racial and ethnic minorities in that group. And you'll see with the transmission categories, it's similar to the national incidence as well. In Montana, about 70% of new infections are MSM transmission, and that's similar to about 2/3, as I said, nationally. Another interesting point I thought on this slide is the age distribution of new infections with HIV. About 50% of patients are under age 40. That means another 50% are over age 40, so not forgetting that this is a risk for patients of all ages, and to keep that in mind when you're screening patients for risk. So just to review the CDC screening recommendations, which I think most of us are aware of, that it's recommended that all adults and adolescents at some point in their life, at least once between 13 and 64, be screened for HIV. But obviously we have to think more about patients' individual risks and what makes the most sense for screening for them. For those that do prenatal care, all pregnant women are screened for HIV in the first trimester as well to try to detect that. But also it's important to consider annual screening for anyone with at-risk sexual activity or intravenous drug use with needle sharing. And one CDC study showed that about up to 40% of patients who use IV drugs will share needles, and upwards of 60% may share some sort of injecting equipment. So it definitely is a high prevalence of risk within the IV drug user population. But also for sexually active MSM, a consideration of every 3 to 6 months screening for HIV, especially given the high prevalence and high risk. It's estimated that 1 in 6 men who have sex with men have risk of HIV acquisition. So it's important to be screening our populations that are at risk more regularly. And it's important to know about some of our resources, which we'll allude to at the end of the talk, in the community that also offer HIV testing. So it's important whenever we screen for any disease, and I have my primary care hat on when I say this, that when we're screening, we also need to think about prevention. And so, we screen for diabetes. If the patient's negative, that's great, but we want to talk to them about how to prevent them from getting diabetes in the future. And the same is true for HIV. So I'm sure all of us have ordered an HIV test in the room, most if you're a clinician ordering labs, but it's important to think the next step in terms of how to give our patients the best education for prevention with all the methods we know to be effective. So just a little perspective on the history of HIV prevention. In the 1980s, when HIV really started to become more known and more understood on transmission, the education was very much on safe sexual practices. And there was a drop in new infections from the 1980s to the 1990s, from about 100,000 per year to 50,000 per year. However, that, as you can see, that number is not very different from the mid-1990s to now. So we've not moved the needle any further in 20 years on new HIV incidents, which is a pretty sobering fact. And so we need to think about new ways for prevention, and that's really why we're talking about PrEP as a new method. So PrEP, again, or pre-exposure prophylaxis, was approved in the US by the FDA with the combination pill of emtricitabine and tenofovir in July of 2012. It goes by the trade name Truvada, for those that may be familiar with that. In 2014, the Department of Health and Human Services and the CDC released PrEP guidelines on how to manage PrEP, how best to approach it, and we'll go through a lot of points from those guidelines as we progress through the talk. And this estimate on the slide may even be a little bit low in terms of the number of patients by this point in early 2016 that are on PrEP. Some estimates suggest 25,000, but I've seen others that suggest upwards of 45,000 patients that may be on PrEP in the United States. But it's also important to think about PrEP is a consideration worldwide, and this is an interesting slide that just shows some of the countries that have either approved or are considering approval of PrEP. At this point, the combination pill, TDF-FTC, is the only one that's approved for PrEP. But we'll talk later at the very end about some other things that are coming down the pike. But it's definitely becoming much more of an effort worldwide to try to prevent the spread of HIV. So now I'll transition to Dr. Haney to talk a little bit about the drug itself and some of the great evidence we have for its efficacy.
So Amy mentioned that this drug is the only drug currently approved for PrEP in the United States. It's tenofovir emtricitabine, or Truvada. It was approved in 2001 for the treatment of HIV, And we have over 9 million patient years of experience with this drug. So it is a very well-known drug. We know the side effect profile. We know long-term toxicities with it and drug interactions. Let's see. Amy mentioned that it was approved in 2012 by the FDA as a prevention option for the transmission of HIV in high-risk patients. It is to be used in combination with safer sex and safer injection practices, and also with regular HIV and STD screening. So Amy will talk about that later. It has demonstrated substantial efficacy in trials, and I'll give you an overview of some of those trials. And it has a very good safety profile also. Just as a refresher, so HIV is a retrovirus, so that means it makes DNA from RNA. And the way that these two drugs work is they're nucleoside or nucleotide analogs, and they're incorporated into the growing DNA chain of the HIV, and that interferes with the reverse transcriptase enzyme and terminates chain growth of the DNA. So it works in that area of the life cycle of the HIV virus. It's a once-a-day drug. Right now it's recommended only for once-a-day use and not non-daily use. There's one published trial that I'll talk about that has on-demand routine regimen, and there's some trials in process right now that also have some options potentially that are coming. But right now, experts and guidelines do not recommend any other use other than daily. It can be taken in with or without food. It does cause nausea, so most of the time we do recommend that patients take it with food. It's important patients realize it's not a morning after pill or a day after or a morning before pill, and it needs to be used daily. The cost is approximately about $14,000 annually, so it is an expensive treatment. Amy will talk later about the costs of HIV infection and how that compares to this prevention method. It's generally well tolerated, so this isn't one of our old HIV toxic drugs from kind of the 1980s. It's not like AZT, it's not like some of the older PI agents that we're familiar with, but it's generally well tolerated. There's a startup syndrome associated with it, and typically patients may have symptoms for several days or maybe up to a month, and then they typically resolve. The frequency rate's about less than 10%, and it can be nausea, rarely vomiting, headache, fatigue, and diarrhea. We have a lot of experience with this drug as an HIV treatment, and typically it's very well tolerated and people start it without any problem. The major toxicity issue that we do have to consider is nephrotoxicity with this drug. It's our main parameter that we have to monitor for this medication. Tenofovir is associated with elevations in serum creatinine and also a rare renal toxicity. It's associated with a syndrome called Fanconi syndrome. So it's important clinicians monitor the serum creatinine. They also should not start this drug if the creatinine clearance is less than 60 or if it falls below 60 during treatment. There's also a slight reduction in BMD with tenofovir. In PrEP trials, that's been maybe not necessarily clinically significant. It's about a 1% reduction in BMD for the first few months, and it seems to stabilize or return to normal with ongoing treatment. There was no increase in fragility fractures in PrEP trials when people were observed for over 1 to 2 years. Oh, sorry, bone mineral density. Sorry, thank you, Dr. Easy. It's also a very clean drug from a drug interaction perspective. It's not metabolized by the cytochrome P450 system. Neither drug in this combination are. There are some other ART interactions, but with a patient on PrEP, that's not an issue because they wouldn't be treated with other ART. One thing that might be a screening pearl for you is that if people are using creatine supplements, that can increase the serum creatinine, and it might be something that we have to think about. If someone has, a young healthy person has an elevated serum creatinine, they might be using creatine supplements. We see that in young, healthy, fit people, men who are exercising a lot, they might be using creatine. So we stop it for maybe a week or two and see if that serum creatinine falls to normal, and then we can determine whether or not this medication is appropriate. Both agents are active against hepatitis B, And that's important if people stop PrEP because they can have a reactivation of their hepatitis B and a flare of the viral hepatitis. Dr. Matheny will also talk about screening initially with hepatitis B. It's a pregnancy risk category B, which is important because some of the women that we might start this medication on may be at risk of becoming pregnant. And this has been a preferred backbone regimen in pregnancy for a very long time and is currently preferred in the perinatal guidelines. There's no evidence of human teratogenicity with either drug, and that's based on clinical trial information and information in pregnancy registries. There is a slight reduction in BMD in newborns who have been exposed to tenofovir. The data has been inconsistent, and it seems to be clinical significance is unknown at this time. Okay, a little information about the trials. So there have been a lot of trials on PrEP, and to note, it's been done in very diverse patient populations. So we have trials that have been completed in heterosexual couples, and IV drug users, and men who have sex with men. So a nice subset or a nice overview of the populations that might be at higher risk of HIV. And these studies have been done globally. They're very well-designed, randomized, placebo-controlled trials. The first trial that I'll talk about is the Partners PrEP study. It's in heterosexual couples in Africa. And they are serodiscordant couples where one partner is positive where the other one is HIV negative. And then the patient who is negative, the person negative, was treated with PrEP. They had 3 arms in this trial. They had the Truvada arm, they had the tenofovir only, and the placebo arm. And in the Truvada arm, there were 13 incidents of HIV, tenofovir alone 17, and placebo arm had 52. So that correlates to PrEP efficacy in this group at about 75% for the Truvada arm and 67% for the tenofovir only. This trial, the adherence rates were much better in the patient population compared to some of the other trials I'm about to talk about. The TDF2 study was also in heterosexuals, and this was in Botswana. Botswana is a country that has a high incidence of HIV, and in young populations it can be almost up to 40% rate of HIV positive people in those age groups. And they did a Truvada arm and a placebo arm. Truvada, there was 9 incidents of HIV, 24 in the placebo group, which correlated to about a 62% risk reduction for HIV. The Bangkok TDF study was in IV drug users in Thailand. They had a TDF only arm, 17 HIV rate incidents in that group, placebo 33%, and that was a 49% risk reduction. The IPREC study was the first study done in MSM, and they also included transgender women who have sex with men, and this was done in Latin America, South Africa, Thailand, and the United States. In the Truvada arm, there were 36 cases of HIV, 64 in placebo. That was a 44% rate of risk reduction. The PrEP study was done in women in Africa and Tanzania. The adherence in this trial was very poor, and the Truvada arm, there was 33 cases of HIV compared to 35% in placebo, and it was deemed no protection, but again, the adherence rate was very, very poor. Adherence drives PrEP efficacy, so this is an important message for our patients. It needs to be taken frequently, it needs to be taken every day. And what they did in these trials is they looked at subsets of patient populations to see how they looked at the patients that were very adherent based on pill counts, prescription refills, and they looked at serum concentrations of drug in their system. And then they adjusted the efficacy rate for adherence rates. So in the Partners PrEP study, the percent of patients that had tenofovir in their blood was 81% in this subset, and the HIV protection efficacy in the original full trial was 75%, and with adjustment it was 90% in patients that had the drug in their blood. In the TDF2 trial, after adjustment it was 78%, and that was based on samples of TDF in the blood, self-report, and prescription refills. The BTS study, when they did the adjustment, it was 70 to 70 to 84% efficacy, iPrex 92%, and then the PrEP study that had poor adherence, the rate was, there was no protection. Another question that you may have is there an issue with resistance when we're using PrEP? And so this slide looks, summarizes the risk of resistance of HIV in the PrEP trials. So when patients had developed HIV after enrollment in the Partners PrEP study, there were 30 cases of HIV in the treatment arm. There were 0 mutations detected in those folks that developed HIV. There were cases where patients had acute HIV infection that was missed at baseline, and they were randomized to the treatment arm and received treatment. There were 8 of those in the Partners PrEP study, and there were 2 incidents of mutations seen to the treatment drugs. The TDF trial, there were 9 HIV infections in the treatment arm after enrollment, no resistance, 1 acute infection that was missed, and that person developed mutations. In the iPrEP study, 36 cases of HIV in the treatment arm, no resistance, 2 undiagnosed acute HIV infections, and those 2 people developed an FTC resistance. There's an interesting trial that's important to know about that has been published with an on-demand treatment for PrEP, and this is called the IPERGAY trial, and I believe this was presented at Journal Club not too long ago. It's a multi-centered RCT conducted in 6 sites in France and 1 in Canada in an HIV-negative MSM and transgender population. They had 2 arms. They have the on-demand therapy with Truvada and the placebo arm. And the on-demand therapy, the regimen they used was a loading dose of 2 tablets, 2 to 24 hours prior to sexual activity, followed by a 3rd tablet 24 hours later, and then a 4th tablet 24 hours after that. If there's multiple sexual encounters, they are instructed to take 1 tablet a day until the last sexual encounter, and then 1 tablet daily for 48 hours after their last encounter. If they're resuming, they repeat the LD loading dose unless the last drug intake was less than a week, and then they only take 1 tablet initially. The results for this trial have been very promising. The mean follow-up time was about 9 months, and they had 16 infections in this trial. There were 2 in the treatment arm and 14 in the placebo arm. It was interesting that the 2 people that were on the treatment side who developed HIV, they were deemed non-adherent to PrEP. 1 person returned 60 out of 60 pills at their month follow-up. The other person returned 58 out of 60 pills, and neither people had any drug, which would not be surprising if they returned all their medicines. Neither had any drug in their system on HIV diagnosis, so most likely they were not receiving any medication for protection. The risk reduction for this trial was 86%, so pretty comparable to our daily when adjusted for good adherence. Both groups took a median of 15 pills per month. There was very wide inter- and intra-patient variability on use. This last slide is where Amy and I will transition, but this is a slide that shows all of the PrEP trials to date. The trials that have performed or shown the best results have been a combination of Truvada, or have been use of Truvada orally, and most have been efficacious, showing efficacy when used appropriately.
Okay, so now I'm going to talk a little bit more about the nitty-gritty of how to treat with PrEP and how to, oh, we have a question.
So the question from the audience is if the number needed to treat was calculated for the IPERGAY trial, and it wasn't reported in the trial, and I didn't calculate it out.
And so, if you know with the other trials that one of the team that with treatment for a year or treatment for 2 years? You know, how long is daily treatment required to prevent this infection? I guess it's probably an email or another. I guess maybe the question is how long is it?
It did vary. So the question is how long those trials were conducted, and it varied, but typically there was about, I would say, probably 9 to 12 months median, and up to 24 months. I'm sorry, Erin, I don't recall the exact details, but I believe it was about 24 months in length on average. And some of the trials, they did have problems retaining people just because of logistics and patient population, but typically it was close to a year. And they did say there might be a treatment effect, that maybe people are better adherent up front when a trial starts, and then over time potentially adherence rates could drop. Any other questions?
That's a great transition, because our next slide is actually talking about that number needed to treat. And there are always challenges in terms of how you calculate that. What's the endpoint that you're using to calculate your number needed to treat? But as a primary care physician, I just thought those numbers really struck me in terms of PrEP efficacy of treating 1 in either 1 to 13 or 1 in 18 can show benefit. And I think it made me think about some of the other interventions we do in primary care that we consider pretty standard part of our job. And I just thought, as you can see on the slide, just the PrEP numbers certainly seem to blow some of those others away that probably are more part of our typical day-to-day practice. My main point in saying that is really to just think about PrEP as being, again, part of regular preventive primary care and the impact we can make on that. So, talking a little bit about candidates for PrEP, and there is a handout at the front that some of you may have grabbed that provides a good summary of this, so hopefully for you to be able to take home, and this distills some of that information. But as we've already alluded to in talking about prevalence and incidence and also the studies, candidates for PrEP include MSM or transgender women with a history of condomless anal intercourse or history of a recent STI. Men or women in serodiscordant relationships with a HIV positive partner. And here, the guidelines mention certainly for the partner who has detectable viral loads, the risk is obviously higher. In studies of heterosexual serodiscordant couples, for the partner who has HIV and is on treatment with a suppressed viral load, that's about a 96% reduction in risk of transmission of HIV between those partners. There's not as good data, or not as much out there in terms of studies for MSM in that risk. So we still encourage patients to use condoms even in serodiscordant relationships. And so for the partner of a patient who is HIV positive, who is interested in PrEP, even if their partner is well controlled, it's still a reasonable consideration to think about PrEP, weighing the cost-benefit analysis and the consideration of taking a daily medicine for the duration of time that might be needed. But it is something to consider, and it kind of gets to that last point about individuals asking for PrEP, really assessing their risk and thinking about what that potential may be. And don't forget, too, that if the partner is HIV positive and their viral load is suppressed now, it may not be suppressed in 3 months, depending on the clinical circumstances. I sometimes have the benefit of knowing that if I'm working with partners together, if I'm treating the HIV, but sometimes you may not know that if you're not treating the HIV positive partner. And others at risk, commercial sex workers, IV drug users who are sharing equipment, or periconception. So if a serodiscordant couple is wanting to get pregnant, using PrEP during the time of trying to conceive is also another use. So the table here is just on the handout that you could have picked up at the front. There should be some left. So that just, again, distills some of the groups that are at risk and gives some highlights of treatment that we'll go through in further detail now. But important to consider contraindications for PrEP before you embark on treatment. You want to know who not to give PrEP to. Absolute contraindications would, of course, be someone who has HIV or proof of HIV infection. Of course, in that scenario, we've already seen that the risk of developing resistance is there, and they should be on a full regimen of antiretroviral therapy. Tenofovir FTC would not be a full regimen. Signs of acute HIV, and we'll talk about the importance of screening for that when you're assessing a patient for PrEP, because if a patient has signs of acute HIV, as you may recall, depending on what HIV test you do, you may not pick up the presence of HIV because of the window period of the test. And we'll go through details of those window periods in just a moment. But it's important to screen patients for acute HIV, especially in the month prior to starting PrEP, so that you don't miss a case. As Kerry alluded to, the risk of resistance could be there, and of course the risk of a missed infection. We already talked about the creatinine clearance that's required for treatment. And if a patient's unwilling to take daily medicine or unwilling to really comply with the follow-up plan, certainly is a concern and would be a contraindication to PrEP, because it's important that patients are getting regular HIV screening, again, to avoid the risk of a missed HIV infection, development of resistance, inadequate treatment. And so it's important to have a conversation with patients about what's needed for proper follow-up and safe management of PrEP. Other relative contraindications, or certainly times where you may need to get some additional consultation, would be a patient with hepatitis B infection, especially with significant liver disease. As Dr. Haney mentioned, if a patient goes on and off PrEP for the purposes of HIV prevention, it could lead to a flare of hepatitis B and potentially fulminant hepatitis. So it's important that we know their status, and we'll talk about that in the initial testing. And osteoporosis also could be a relative contraindication, given some of the evidence we have about decreased bone mineral density. So preparing for PrEP, what are some of the initial tests that you want to consider? And we'll look at a little bit of an algorithm from the CDC guideline in just a moment. But HIV screening, of course, is important at the initiation of PrEP. And which test may depend on the patient's history, recent exposure, what your concern is for the potential for acute HIV. So we'll go through that in a little bit more detail in a moment. I already just talked about hepatitis, and so it's important for hepatitis B and C screening. C because the same risk factors that many patients have for acquiring HIV are also risk for hep C, and we don't have prevention methods for that, at least other than what we have already had for HIV previously. And for hep B screening, it's important to get a surface antigen, so that way if that's positive, you definitely want to do further workup before starting PrEP and understanding the status of their hep B infection, getting a hepatitis B viral load before starting FTC TDF, so that you don't suppress their hep B and not have known that they actually had a chronic hep B infection. It's also important to assess their immunity, so if they are non-immune, that you vaccinate those patients against hepatitis B and protect them, since it's still another infection that you could be at risk for. We talked about checking a creatinine, which is important at initiation, and urinalysis can be helpful for a baseline as well, since tenofovir can lead to the potential for renal toxicity. Knowing what their baseline is in terms of proteinuria can be helpful, so if they develop it later, you can have a sense of what their baseline was. And STI screening. It's very important to remember that, both at the initiation, because the patient may be at risk of that as well, and also subsequently in follow-up, and we'll talk about intervals for that. And not only gonorrhea, chlamydia in the urine, but thinking about site-specific testing, and I'll show a slide that really drove this point home for me in terms of the importance of considering what sites should be tested for gonorrhea, chlamydia, and not forgetting screening for syphilis. It's certainly in our MSM population, there's a high prevalence, in Montana included, so it's important to remember to screen for that as well regularly. And pregnancy testing if relevant for female patients, and think about contraception if they are not desiring to get pregnant. So the HIV screening before PrEP. The CDC guidelines suggest that there should at least at minimum be documentation of a negative HIV antibody test within 1 week of starting PrEP. Oral testing is not adequate, so if a patient maybe did a home test, you can't use that. You really need to have some sort of serum test, although a rapid test is certainly a viable option. If it's a patient self-reported test, you really want to either have documentation of that or repeat it in the proper time frame so that you have confirmation, again, before starting PrEP. And consider any potential recent exposures. You know, does the patient have risk of acute HIV? Do they have an obvious known recent exposure that you really are concerned? Do you need to assess for HIV before starting PrEP? And again, screening for symptoms of acute HIV, which we'll go through in just a moment, within the past month, so that you know if you need to do some sort of different testing than an antibody test. As you'll see, the window period for that may not be adequate to detect acute HIV. So this algorithm comes from the CDC guideline, and so you can refer to that for a refresher. But so the initial HIV antibody test, maybe a rapid test. If that's negative, then you do want to still screen for symptoms of acute HIV infection in the last 4 weeks. And if there is concern, which of course, as we know, a lot of those symptoms can be nonspecific, they've had a recent cold, there could be a question of that, so it can become challenging. But you have a few different options on how to proceed. I think many people think of the viral load, the HIV viral load, as a way to assess for that, but that can be an expensive test and may not be the most cost-effective option. You've got to kind of use your judgment on what might make the most sense for the patient as well. One option would be to defer starting PrEP, wait a month and recheck an antibody test. Another option would be checking a 4th generation HIV test. Have people heard of the 4th generation test? Has anyone heard of that test? I know at Partnership, most of us have heard of it because our lab has switched to that, but that's a preferred initial screening test. Rapid tests are very good options as well for convenience for the patient, but a 4th generation test can be very helpful to detect acute HIV, and we'll show why in just a moment with the window periods of these tests. So you have a few different options on how to proceed if you're concerned that the patient might have had a recent HIV infection in the last 4 weeks. But a reminder on some of the symptoms of acute HIV, the overall category is probably most helpful here. But as you can see, there's a number of different symptoms, and fever is probably the most common in 75% of patients. That's only 75%, and a number of these other symptoms occur in less than 50% of patients. So it's important to just build an awareness of what these symptoms are and have it in your arsenal of screening when you're seeing patients who are at risk. So you just make sure to not miss an acute HIV infection. So this is just an algorithm showing the 4th generation test. Our lab has switched to that as a preferred test unless we're doing a rapid. And the 4th generation test is testing not only for HIV antibodies, but also for the P24 antigen, which is part of the viral capsid. And so this can be detected sooner, and I'll show that on a slide in just a moment, but it allows for the detection sooner of HIV and often of acute HIV. If the test often includes a reflex to an antibody, and so if that's negative, it can then reflex to a viral load, which hopefully could then confirm the status of the patient. And this is a slide courtesy of the HIV telemedicine resource we use through the University of Washington called AETC ECHO. And this shows one picture of the window periods, but I'll show on the next slide a little bit easier to read version of this. But as you can see, the HIV RNA is what rises first in the setting of an acute HIV infection, followed by the P24 antigen. But as you can see there, if the patient had an exposure 3 days ago, you're not going to detect the virus yet either if you draw the blood today. So it's important to understand these window periods as you're assessing patients so you can feel comfortable knowing what test you ought to do to be sure that they don't have an acute infection. I find this slide a little bit easier to read and understand in terms of thinking about the window periods. And so if you're checking an RNA test, generally think about it within 1 to 2 weeks, but probably closer to 10 to 14 days in terms of positivity. So you do still have a window where it could be missed. The P24 antigen kind of represents that 4th generation test, and that can usually be detected within 2 to 3 weeks of HIV infection. The antibody test that most of us are probably familiar with previously, usually about 3 to 4 weeks until that turns positive. And the rapid tests tend to be between 4 to 5 weeks. And these ranges are also quoted in the CDC guideline if you need a reminder about that. Just another slide that I saw at a recent conference that I really thought was very helpful is in terms of GC gonorrhea chlamydia testing. And just a reminder again for site-specific testing. And this study looked at simply checking the urine, so essentially a urethral screen for a group of MSM at San Francisco City Clinic, and then compared that to also pharyngeal and rectal testing, and that almost 60% of GC and chlamydia infections were missed if only relying on urine testing. So don't forget to consider either pharyngeal swabs and or rectal swabs. It's similar for our lab as using the cervical swab, so if you have a question on how to collect that, it's the same swab we use for cervical GC chlamydia testing. And there's also the ability for self-collection for rectal swabs, and so we give our patients a guide for that, and it just helps with patient comfort for testing and uptake of testing. So some additional discussion points for starting PrEP with your patients. The CDC doesn't recommend giving more than a 90-day prescription because of the importance of regular screening for HIV while on PrEP, because you don't want to miss the patient actually contracting HIV and subsequently missing the opportunity to change treatment. A 30-day prescription can also be considered initially so that you get the patient back in for rescreening, because the CDC does recommend a retest at 1 month to ensure that they're not infected. And then subsequently talking about effectiveness, that patients really understand that the evidence we have from studies still is paired with safe sexual practices and education on this, condom use, and so it's important that PrEP alone isn't the only protection that they have. Talk about potential side effects of the drug, but still also emphasize that this is very well tolerated, and the nephrotoxicity is a consideration, but most patients don't develop that, and so it's important to also reassure patients of the tolerance of this drug. Important point also to let patients know about, of course, the importance of adherence, and that the studies really show that good number needed to treat in the setting of good adherence, but also the window period to effectiveness. And I'll go over a little bit more detail of that on the next slide. But patients need to know that if they're on PrEP today, tomorrow they're not protected, and so there is a window period before that's going to work for them. And the importance of regular HIV and STI screening and letting them know the signs of acute HIV, so if they develop those symptoms, that they come in right away for an evaluation. So there's not perfect data to really understand the time to effectiveness of PrEP, but the levels may differ depending on the tissue. So some studies have shown in blood and cervical vaginal tissue about 20 days to adequate drug levels. Rectal tissue only 7 days, but from some of the experts we work with, including the PrEP clinic in Seattle, their recommendation is to give patients 30 days to ensure effectiveness of PrEP. So it's important to, again, give patients that perspective so that they know within a couple days of starting they still may not be protected. So follow-up monitoring, and again, a lot of this is outlined in the reference, the fast facts on the sheet in the back of the room, but important for every visit to assess adherence because, again, we know that that really is what drives the effectiveness of PrEP. And at this point, even though the EPRGay study is out there, patients may be aware of it and asking about on-demand PrEP. At this point, our national guidelines are for daily use. Talk about side effects, screen again with each visit for symptoms of acute HIV, and continue counseling for safe sexual practices. At 1 month, a repeat HIV screening should be done, and at that point, if the patient's doing well, a refill for 90 days would be appropriate. And then every 3 months, repeat HIV screening, repeat STI screening, as we've discussed previously, pregnancy testing for women if relevant, and you know, the CDC recommends not continuing prescription past 90 days if patients aren't coming in for that testing. I think for all of us that can become a challenge when you have a patient that's not following up but you know needs a certain treatment. But really for safe administration of PrEP and really to not be prescribing PrEP in the setting of an undiagnosed HIV infection, that could also be detrimental. So it's important to emphasize this importance to patients. And it also could be, you know, a nurse visit. If you have a nurse that's trained in terms of what needs to be screened and to check in with patients, that could be a great example of team-based care. But it's important that the patient's getting in the door and getting the adequate testing and discussion every 90 days. 6 months, good to check a creatinine and follow that over time. As Kerry already mentioned, if the creatinine clearance remains above 60, it's okay to continue, but if the creatinine is rising, you do want to follow that more closely, and you may check more frequently in patients at risk, such as patients with hypertension or diabetes. Remember, over 50% or 50% of our patients who in Montana got HIV were over age 40, so a good chance that some of them may have some of these concurrent issues. And annually should screen for Hep C because, again, can be similar risk factors as their risk for HIV. And a urinalysis to check for proteinuria, again, looking for any evidence of renal toxicity. And whether it's at a year or sooner, you're reassessing risk of HIV infection. And does it make sense for the patient to stay on PrEP? Because it doesn't necessarily mean this is a lifetime medicine, depending on the patient's circumstances, but you want to reassess if PrEP is reasonable for the patient to continue. And if you are thinking about discontinuing PrEP, there can obviously be lots of reasons for why that might be. Patient choice, maybe they're having side effects, maybe their creatinine clearance has dropped below 60, or if the patient's just not adhering to PrEP and not following up, that may be a circumstance where it needs to be discontinued. Preventive practices, counseling still remains and should always be part of our care. And it's important to document an HIV test at discontinuation and also to have a sense of recent exposure. So do they need a follow-up test in another month? You know, keeping that in mind that the risk may still be there. Really important point, though, is counseling patients about restarting their PrEP. If they have a half bottle left and they decide they don't need it anymore and want to stop it, patients really have to understand to not restart it on their own because they may not have that updated HIV testing before restarting, and we could, again, be in a detrimental situation of treating with PrEP if they're actually infected with HIV. So it's important to encourage patients, if you want to start this again, come back in, let's do this process, so that way they can just have proper monitoring and guidance. So there can be lots of challenges, just like all the things we treat, in how to manage PrEP and some of the issues that can come up. One of the biggest issues, though, is really engagement and care for at-risk populations in the first place. We know that there's a lot of disparities in care, especially for transgender women, one of our most at-risk populations. And so it's really important to have patients in care, and when they're in care, use the opportunity to really assess risk and offer them treatment, and also to have an approach to care that really makes patients feel comfortable. Important considerations, again, on the HIV test and the window period. We already talked about that. Concerns about compliance and follow-up. Really touched on a few of these points. And also the duration of treatment. Again, how long does this patient need to be on PrEP? Is it episodic because of a risk that's anticipated, such with periconception, or is it something that might be long-term if they're in a relationship with an HIV-positive partner, and how long does it make sense for them to be on PrEP? So sometimes some tough decisions that don't always have clear answers, but definitely some of the challenges we can see. There's some ICD-10 codes if you're interested. These are available in some references I'll allude to in a moment. But cost, I'm sure that must be a question on people's minds. Kerry already alluded to the cost that can be between $12,000 and $14,000 a year. So it's obviously not a small deal to be considering use of PrEP. Interestingly, though, our experience has been that most private insurance companies are covering PrEP. You probably have to do a prior authorization. You can guarantee there'll be some paperwork with starting such an expensive drug. But we've had very good luck with our patients being approved. That being said, I've been on some listservs of folks in other states where some of the insurers have required that the patient's PrEP only be prescribed by an HIV specialist or an infectious disease specialist. So it's really reduced access for a lot of patients. That's not the case in Montana yet, but it may be an advocacy issue for the future if that comes up. But for now, it's really any prescriber that deems it's appropriate and fills out the paperwork correctly. Uninsured patients can get patient assistance from the drug company that produces Truvada, and it's a pretty quick turnaround time, 2-day turnaround, and for patients are eligible at or above, at or below 500% of the federal poverty level, so a large number of patients could be eligible for this through the drug assistance program. But the Montana AIDS Drug Assistance Program and IHS do not pay for PrEP, so if that's a question from patients, unfortunately those are not resources. So the cost effectiveness of prevention. This is not necessarily a cost effectiveness study of PrEP itself, but it looks at the lifetime medical costs that are estimated for a person with HIV infection versus someone who's not infected with HIV. And I would argue some of these estimates probably are even lower than they could be, because if you imagine a patient with an incredibly severe opportunistic infection and a very long hospital stay, their lifetime medical cost is probably a lot higher than what's quoted here. But this study, or this estimate of costs, was based on acquisition of HIV at age 35, and also took into consideration the fact that many patients are living with HIV now and dying of causes that are non-HIV related. So they develop heart disease and diabetes and may die from those causes, and the HIV is another chronic illness that they're living with. But the costs are obviously very high, and as you can see, 60% of those estimated costs are just the antiretroviral drugs, which they'd be on more than just the FTC TDF, but those are quite expensive, and some of the other associated costs. But if you do the math, averting one HIV infection just from this estimate saves about $230,000. And if you're doing the math on your smartphones, if you divide that by the cost of PrEP, that's about 15 years of PrEP. So it gives a sense even though they don't talk about PrEP per se in this study, it gives you a sense of thinking about that cost effectiveness. So I want to highlight some great clinical resources, some of which are specific for PrEP and others that are just great for HIV in general. But the CDC PrEP treatment guidelines has been our resource for this talk and for the standard of care in the US, and it's a great read. It's not as dry as you'd think. And so keep that bookmarked if you're finding that PrEP is something you'd like to start doing. I don't know if people are familiar with this, but UCSF also has a fantastic resource called the Clinician Consultation Center, which is sort of an on-call center for HIV questions across the board. HIV perinatal care, newborns that might have been born to an HIV-positive mother, but also they have a PrEP line, so it's 855-HIV-PrEP. Pretty easy to remember, and the hours are there on Mountain Time, and so if you have a question about that, you can call that hotline and get some advice. Certainly we at Partnership Health Center and the HIV services are also a resource, and we're happy to be there. We don't have a fancy number, but you can just call Partnership. And also, I always like to make this point for people to be aware of too. If you do OB care and a patient rolls in the door in labor with HIV, you can call this number with a broader range of hours of availability to have some help. So it's important to know this is a resource. Post-exposure prophylaxis is another example of kind of a last-minute phone call that they can be of help with. And there's also some great resources from the New York State Department of Health. The first link here, the CEItraining.org/PrEP, has some great CME. You can get CME by doing some of their online modules, case-based examples. So it's a great resource for learning. And also want to highlight a supplement to the CDC guidelines, the clinical provider supplement, that has a number of documents that really can help you in your care of patients for PrEP. There's patient and provider checklists, so just to give you a reminder before starting PrEP, patient education handouts about PrEP and effectiveness, side effects, pregnancy and breastfeeding, and just ICD-10 codes if you need some of those. So it's got some great resources, so I encourage you, again, to have that bookmarked if you're going to be pursuing PrEP care. And again, to highlight some of our local resources as well, Open Aid Alliance is a great local organization for both HIV prevention and advocacy and offers testing for HIV and hepatitis C. So it's important to let your patients know about that. Also needle exchange services. Partnership Health Center, again, our HIV services is always here as a resource and welcome to call us. The State Department of Health and also the Montana Gay Men's Task Force is another great local advocacy group, both to refer your patients and also for you to be aware of. So I just thought this was a neat slide to end on with some of the drugs, many drugs and formulations in the pipeline for PrEP. And you see examples here of not only pills, but injections, vaginal rings, vaginal gels, rectal gels. I don't know what a nanofiber means or what that could be, but that sounds like it could be an interesting thing to study for PrEP. So maybe a PrEP microchip, I don't know. But so there's a lot of things coming down the pipeline. And so I'm sure in the years to come, we're going to hear about a lot more options. But as of now, there's only one to know about, so it makes it easy to get started. And I just wanted to highlight that I mentioned there's a few community talks. One has already happened earlier this week north of here, but we have one happening in Missoula at Imagination Brewing, really geared towards patients on Wednesday, March 23rd, 6 to 8. So there'll be a panel discussion for patients. So if you have patients that might be interested in learning more, you could refer them to this. So we'll end on any questions you may have. I'll leave this up for information. Yes?
I understand the desirability of treating HIV infection as early as possible, but somehow your testing paradigm seems awfully obsessive in that area. I mean, I have a hard time getting in to see my GP. How can these folks just be constantly coming in to get their HIV tested?
Well, you know, I think for us at least, and we often can have labs just as a standing order for a patient. So if they know, you know, in 1 month we want you to come in and have this done, just having that order standing at the lab for the patient could be one way to do it versus, but ideally you want to be able to at least sit down at the first month to assess how things are going and make sure adherence is good. So I think on the one hand, it's part of that discussion at the very beginning of initiating PrEP that patients understand the importance of that close follow-up. Hopefully once you get past that initiation screening, the 1 month screening, we loosen up a little bit with every 3 months. Yeah. And it's just the ongoing risk of exposure and definitely the risk of them being on it for a longer period of time without noting that they're actually infected.
In your patients who have a tendency to have renal insufficiency or have high risk for that, have you ever thought about using the other tenofovir, ralafenamine?
That's
I mean, and would you get denied?
Kerry, do you want? Yeah.
So there's a new form of tenofovir now available. Tenofovir is a prodrug that's converted in the plasma, and there's about a 90% systemic exposure. So tenofovir disoproxil, I think, something that TDF that we talked about. This has the renal toxicity, but they found a more efficient, more effective prodrug that's converted in the cell rather than the plasma, and it exposes the kidney to less drug. So TAF has not yet been approved, and I don't believe there's been any studies yet for PrEP. I think the thought is most likely it may be an option, but people are hesitating right now because they don't know if the efficacy is the same compared to TDF. Most likely we wouldn't see a difference, but we don't know yet.
Yeah, it's anticipated that they're going to request approval for TAF-FTC for PrEP in the near future, although TAF-FTC has not even been released yet, but later this year it will be. But so it probably wouldn't be.
It's a Gilead drug as well.
Say that again?
It's a Gilead drug.
It is indeed, and but at this point it wouldn't be approved by insurance just because it's not FDA approved yet. It's a good question.
I guess you guys covered it all.
All right.
Wonderful
Thank
presentation.
You so much.
Thank you so much.